Thanks for everyone who's shown up in person as well as those online for joining us for this evening's event. This is the third of our quarterly health policy seminar series events, jointly sponsored by the School of Medicine and the Institute for Population Health. I'm Scott Shipman. I am the leader of the Institute for Population Health here at Creighton and a member of the School of Medicine as well. We appreciate the partnership with the school in running these events. Tonight, we're going to have a moderated panel discussion focused on the critical issue of societal and patient trust in healthcare. Today, we have a distinguished panel of experts who will help us explore both the roots and contemporary manifestations of mistrust in healthcare, and most importantly, discuss actionable strategies for rebuilding faith in our healthcare institutions. Just to set some context, a recent national survey of almost 500,000 US adults found that the trust they had in physicians and hospitals fell by more than 30 percentage points between 2020 and 2024, from 72% down to 40%, with declines really across all sociodemographic groups. For a subset of our communities, particularly those from Black, Latina, and Indigenous backgrounds, this collapse in trust layers on top of historical mistrust that's been well earned. In recent history, trust in agencies like the CDC has declined considerably amidst conflicting guidance during the COVID-19 epidemic, and most recently, questions around childhood immunizations and how politics have become quite intertwined with policy. Finally, we have the wonderful influence of technology, things like social media and AI, which layer on additional mechanisms to sow mistrust and misinformation. So certainly these are challenging times, but we're fortunate to have gathered a group of experts who can help us identify the solutions as well. Not to put too much pressure on. I'm going to let the panelists introduce themselves, but I will just briefly point out that we have Shanika King-Parker immediately to my right, the founder and CEO of A Mother's Love. We have Dr. Deyanna Boston, family doc with Creighton and CHI, who practices nearby in North Omaha, and Selene Espinoza, the market manager for workforce development at CHI. Each bring their own professional and personal experiences to this topic of trust and mistrust, and I'm very much looking forward to having a dialogue. We will be having an opportunity for dialogue with the audience as well, and look forward to audience questions, both those here in person and those who have joined online. We'll save plenty of time for that conversation. And for those who are in person, you have the opportunity to also join the panelists at a reception afterwards, talking with them. So I'm going to join the panelists here in my seat momentarily, and as I do, I'd ask each of them to introduce themselves, and maybe we can start with Shanika and just go down the line. And as you introduce yourself, if you would, please share a personal and/or professional experience that informs your point of view on the topic of trust and restoring trust.
Yes, definitely. Hello, I am Shanika King-Parker. I am co-founder and executive director of A Mother's Love. We are a pregnancy support agency located in northwest Omaha, serving all of Nebraska, whoever kind of needs our support. Through that, we have community health workers, doulas, supplies for mom and baby, and also just support around helping them with their different social determinants of health and different things that they have going on. Personal experience when starting this about 22 years ago, being just in the OBGYN field, I was a medical assistant. And when me and my business partner, Nakia, would take clients back from bringing them back and different things, they would share so many different things with us that they wouldn't share with their doctors. So they'd tell us things that they were going through at home, things that they were missing, things that they didn't feel comfortable enough letting their doctor know. So during that time, we were, helping them. There wasn't really a name or didn't know about the things that we're doing now that we could do back then, but being able to support them and hear what they were saying helped us be able to mold and shape what we do now. Ways outside of the healthcare setting.
Hi, I'm Deyanna Boston. I'm a family physician that practices OB.
assistant professor with Creighton University School of Medicine and employed by CHI. So I work at Charles Drew Health Center, which is one of the local FQHCs here in Omaha. And I also work at CHI's office right across the street. I don't know what my parents, I think it's that way. 24 in the coming, where we take care of moms and babies, so pregnant women and newborns. I think as a Black woman, my experience in healthcare is pretty unique because a lot of patients that are ethnically similar to me will seek out my care. And I think just being in that position to be able to serve those patients makes a difference. Kind of like what Shanika is saying, I think a lot of patients feel more comfortable talking to us about whatever is going on that they might not have felt comfortable with other healthcare professionals. So I think it's a really unique opportunity, a unique place to be in. And I don't take it lightly. I really try to treat all my patients the way that I would want my family members to be treated, and give them the advice, whether it's, in a very professional tone or a very laid back tone. I think that patients appreciate it.
Hello, everyone. My name is Selene Espinoza. I am currently the market manager for workforce development for CHI Health. My former training, I was as a surgical assistant for 22 years. So I feel like I have a very close experience and personal experience to our topic today. Personally, I would say it really has impacted me as a person, being a proud daughter of Mexican immigrants. My parents have worked in the meat packing industry for 22 years as I was working as a surgical assistant. So during the COVID era, it really hit home in both places. It hit home because my parents were declared essential frontline workers. And then in my side, I was declared a frontline healthcare staff member. So that experience really pushed me to be very intentional about the work that I do within my profession and my community as well. So very happy to be here. Thank you.
Well, one way to think about topic of trust discussed in healthcare is to think about those factors that have been around as distinct from those that are more recent factors driving distrust with healthcare. I mentioned sort of passing for minority groups in particular, there have been a number of well-publicized, but perhaps not enough publicized affronts to trust that come from healthcare, the research world, as well as the clinical care. I guess I just want to open up a question generally about your perception.
I think a lot of us know about, history of OBGYN surgeries on enslaved women without anesthesia. And that's how we get a lot of the common practices and surgical procedures that we do now. People still remember that. Things when it came to like the Tuskegee Project with syphilis and not treating those patients. I think a lot of minorities, especially African American patients, they still remember that, and I think a lot of people stay away from the healthcare system because they don't know what are we putting in their bodies when it came to the COVID vaccine. What are you really giving to us? So really trying to be in a position where we can educate them on what's happening now, kind of apologize when we need to for what happened in the past, and just try to move forward. Sometimes it's a challenge, especially with older people. But also I think when it comes to younger patients, they have technology at their hands, so it can be a blessing and a curse in a lot of ways. But really just try to provide evidence-based care and evidence experience on why we're offering certain medications and treatments and recommendations. I think that is what will kind of take us to the next level, for people to be a little bit more trying to do for them. like Dr. Boston said, also thinking about that it's all passed down. So generation for generation, mistrust is being passed down from grandparent, from mother, from someone in that family. Those are trusted individuals. So I believe breaking that cycle, helping that trust, because you have people in place that community that can kind of break that barrier, kind of explain what's going on, and have that trust in the community. And see those people are in their community. They look like that's in their community. So being able to go to them because they know the person in the community health worker do love medical assistant nurse knows both sides. They live in that community and they work in that field, so they can break down those barriers and be able to explain a little bit more and help understand, like, oh, okay, maybe it's not really like that. That was maybe before and long ago. Things are changing now. Just continuing to integrate that and build that trust with the community and the healthcare. Just bridging that gap, I think.
Let me just pick up on some of the last points, Shanika, that you made. We sometimes talk about the social distance between healthcare provider and a patient as a barrier to trust. When you talk about doulas and community health workers and other similar roles that exist with the express purpose of reducing that social distance, it sounds like you're a firm believer, and I know you are a firm believer in the power of that. I wonder if Deyanna and Selene, you might offer your thoughts on the reality of social distance being a barrier to trust just in its own right, and the impact or possibilities that bringing in a workforce that is intently there to reduce that social distance, what that role is.
Yeah, absolutely. I think there is many factors when you talk about that relationship between the caregiver and the patient. I think we have to really focus on that model of seeing the patient as a whole patient and treating them with really culturally sensitive education, um, and then also just being able to recognize that we are I understand healthcare is a business, but I also do feel that there's a lot of pressure for our providers. They've limited their time that they spend with their patients. They've limited a lot of communication. It's mostly digitally now, so it's not in-person communication and education. So I think that's also has some negative impacts in how we are treating our patients. But of course, it also has to be with the workforce really um, being able to be diverse and represent the communities that we serve. I personally had that experience when COVID came through our healthcare systems. The surgical staff were pulled. We were no longer doing elective procedures. We were only doing emergency services. So I stepped into the role of being able to be a medical translator for those patients because, again, they were our front essential employees, and most of them were Spanish speaking. So that really impacted the care that they received. So that, again, it really ignited my passion to be able to then move into the workforce development manager role, to be able to open and create those career paths internally with the support of Common Spirit. They really have provided support. They see the value. They see how that changes the patient experience, but also internally, how well we're able to work in teams to support our community.
I think cultural congruence is really important, but it's not the end all be all because we are able to bridge the divide between patients and caregivers or clinical staff pretty easily. We usually get like 30 seconds to build rapport with a patient when you first meet them. And, if you just walk in and treat that patient with dignity and respect, I think you'll build a good relationship rather quickly. Like Selene was saying, there's a lot of things that you do have to take into consideration nuance wise when you are dealing with patients from different ethnic backgrounds. There's going to be recommendations that might be standard recommendations, but you have to think about, what are a certain culture's diets like, or what are
the barriers to transportation or housing or economic barriers. So we might not be able to recommend expensive medications for everybody or tell someone to go and exercise at the gym because that might not really be realistic for them. So really just taking into account who is sitting in front of you and asking them um, what their barriers may be and making sure that you try to meet them where they are.
That's great. So this notion of the concordance is important, but not the only way to gain trust. Selene, you mentioned in your response just now uh, the challenges of the pressures of how we deliver care today. And you didn't use the word impersonal, but I think that's what I heard in your statement was that if healthcare feels quite impersonal. And I'm sure we each have our own perspectives as patients and being on the other side working with patients in a variety of ways about that. Can you talk more about, and maybe each of you have some thoughts to offer along the challenges of the way healthcare is today and what remedies might be there for those challenges?
I think one of the challenges that I have personally witnessed is how we're using technology to be able to deliver care in multiple languages, which is using a monitor, and we can reach many different languages and we can provide services in many different languages. But I think we have to really look at those spaces where those services are provided, a monitor versus an in-person translator, because there is some very sensitive patient care areas where I feel that that in-person care will really make a difference in the outcome of the patient. Especially personally, I have experienced it when patients are coming out of the OR and they're still under anesthesia, and maybe they have other factors such as maybe they're elderly, obviously a language barrier. You're coming out of anesthesia, there is a lot of anxiety and fear, and then our providers are trying to communicate with them via a monitor. So that really has not worked again in those areas, specific areas. So I think as healthcare looks at expanding those AI services and technology services, they also need to look at where they're implementing those. There is a lot of room for that growth, and I support that growth, but we also have to identify those areas because I personally feel like they should not be part of the post-operative care.
For me, it is a lot of pressure coming from the healthcare system, from the insurance companies. Patients don't realize that a lot of times they might get a 15-minute time slot for their appointments, but that 15 minutes is from the time you check in at the front desk to the time that I'm going into the room with the next patient and everything in between. So for the patients that have not been in the healthcare system for a long time that might have a lot of issues going on that need to be addressed, medical, social, do they have insurance or not? We cannot take care of everything in one visit. And I think really trying to set expectations up front with the patients is really important. So I might have to have a patient come back every week for 2 months so that we can try and address one thing at a time, but really trying to get them to understand that you can't sit here in the office for an hour every time you come, not because I don't want to see you, but because the pressure from the system won't allow that because they want 4 people to be in that 1 hour time slot versus one person. So really trying to set clear expectations up front. And I always will tell patients, I can't do everything today, but we'll work through it and I'll put you in touch with people who can help on the back end for some of the things that you don't necessarily need my expertise for. And I think that helps um, bridge some of those gaps a little bit. And then they understand, okay, she'll be here next week. I can come back again and kind of work through all the concerns that I have.
Just like Dr. Boston was just saying, doctors have a
lot to do in a day and charting and different things like that. And I've seen it on both sides, being in the clinic and in the community side. So I believe letting our community know that we are all a team and that we're all working together. It takes a village for everyone to be able to get through the things that they get through just on a regular basis anyway. So being able to let our clients, our patients know that we're all a team. Like Dr. Boston said, I can't get to you in this portion, but I also have a community health worker that can also see you. I also have a doula that can also see you. I have WIC. I have different things. So hitting everything that they need done helps them feel, I believe, just building that trust. Like I have a team. I know that I have a village when I go to my doctor's visit or when I go and see someone for my care, that someone is there to support me in all these different areas. And if it's not in the healthcare setting and maybe it's in the community, but they see that all of us are working together to get it done.
I hear a lot about the time constraint in those responses, as well as the influence of technology. I can't help but think back. Some of you might remember this. There was a JAMA cover, Journal of American Medical Association cover, that a 5 or 6-year-old drew. That was his or her, I can't remember, a picture of what a doctor. And it was a child sitting on the end of the examination table, and the provider corner staring at the screen of his or her computer. And to the extent that that's the view of sort of the purest view coming from a child of what a healthcare encounter looks like today, it's not too surprising that that it feels impersonal. This is a little bit of an in-weeds question, and I'll direct it at Dr. Boston. There is perceived to be a light at the end of the tunnel with technology in the form of AI supporting clinical documentation, and some debate about whether that will or won't help bring the patient-provider interaction more front and center again. What are your thoughts on that?
I think AI is helpful for a lot of people. I personally don't have any um, opportunity to use AI in my clinics. I don't. I think my patients would say that their appointments with me are fairly personal because I don't chart in the room with them, and I usually just sit across from them and talk to them. There's some weird way that I remember quite a bit, so I don't take a whole lot of notes. And so they feel like we have a connection, which I think really helps. But there's some physicians that see 30 patients in a day, and I can see where AI would help keep them on track with their notes. I mean, I've built templates and smart phrases and all of these things to try to help me on the back end so that I'm not doing a whole lot of work after hours. But I do think my patients feel a connection, and they wouldn't say that I'm just sitting in front of the computer, because I actually don't use the computer in the room when I'm with the patients.
Sort of the two sides of technology. There's hope potential, but both in the context of having an interpreter who's either there or on a screen, a doctor who's either there or not really there in the room with you, I think are two examples of where technology can get in the way. Let me pick up on a thread around the team, Shanika, that you referenced. And I'm not suggesting this is your point of view, but many physicians do sort of tend to lump on their shoulders everything that a patient needs. And increasingly, we have tried to grow the team around our primary care providers, but really all specialties as well, to help support the diversity that patients come in with, some of which might not be best handled by the physician, by a pharmacist or a nurse or a community health worker, and on. Can you talk a bit more about the role of team-based care as an enabler of trust, as well as any cautionary notes about how potential fragmentation of the team could negatively impact trust in the relationship between the patient and your team?
Yes, definitely. So as you know, in a team, we're all working together, and when we're all at the common goal and trying to support the client or patient, being able to come together. There might be not disappointment, disagreements. There might be different things, but not letting our communities that, not letting them, because we're already trying to build the trust of them, of the community, for them to come and get the care that they need. Because there's, our maternal health rate is high. There's other things, high blood pressure, heart, different things. So in order for us to keep our community around, there's things that we have to do as a team or as a village that takes a little bit more. And that's just, I think, believe just all of us coming together and looking at, like she said, the whole client, our whole patient, and things of us not working together can fragment that, because if they don't see us all working together, they don't feel that they all have to work together or be a community or look out for each other, or even go into these different roles that we do have: doctors, nurses, community health workers, doulas, and staying here in our community because they see the things that we are working on, trying to do better. Trust.
Great, thanks. Other thoughts on this question about the role of teams in building trust or eroding trust?
It's definitely important because we can't do it all by ourselves. So having the pharmacist, the community health worker, the nurse, it's critical, but then also making sure that there's someone who is like the common person that can help synthesize all the information that's coming from all of these different resources that we're referring people to. I think if, Shanika and I talk all the time, hey, I referred a patient to you. Did you hear from them? So really closing the loop is really important so that the patients don't feel like, well, you sent me here, but I haven't heard anything, or what am I supposed to do next? So we really try to make sure that we definitely have good lines of communication and have somebody that's following up, or have a process for us to follow up on if we sent a referral to this place or this place or this place, that we talk to those patients to find out if they got the services that they needed from those different people.
I can add to that. I would see the team approach. Then the way I guess I view it is really reaching out to those community partners to be able to build that bridge and that trust within community and healthcare. So, for example, I can tell you that yes, my role is workforce development, but I really focus on um, being a connector within the healthcare in my community, because I know that there is a mistrust in the Latino community. Um, so, an example that I can provide is that I work directly with the Latino community, and I serve on the Douglas County Board of Health. So I am the person that organizes vaccination clinics at the Latino Center of the Midlands. I also reach out to Methodist Health System to do their mammogram bus. So we bring those services to our community. So patients feel that they are supported, and that those are providers and services are coming to their environment, to their safe space. And I think that really has helped build that trust.
Well, gosh, that's a powerful example. I'd love to lean into that further. The role of, there's two parts to my question. Start with where you started, Selene, which is how can the health system most effectively reach out into the community, not just sit back and wait behind the walls of the hospital or the clinic for the community and the patients to come to them. What are the opportunities there? Where do you see bright spots? Where do you see opportunities for us to do more in our various health systems? I'd like every one of you to think about this.
Like I said, I think it does take someone from that community to initiate that almost invitation of services brought to our communities. But it also takes a lot of support internally from those health systems to recognize that that person or that staff member or that doctor is wanting to create that bridge, and they support it with either staffing a healthcare fair or a vaccination clinic, and just seeing that value and supporting internally their employees that are really trying to uh, portray the healthcare system in a positive way in community. I can give you another example of how CHI really supports the Latino community. we participate in the Cinco de Mayo festivities. So every year we provide a healthcare fair that is staffed with a very diverse staff members that volunteer for that. And they come to South Omaha and they do a lot of different healthcare screenings. And again, it's just that they see us in the community, they see representation of their community, but they also see a lot of other diverse healthcare staff engaging with them and being willing to volunteer their time and to be there and celebrate not only healthcare, but also the culture and the festivities. So again, just building that trust and that bridge.
I agree that working for a healthcare system that is willing to go out into the community is important. So, CHI has participated in quite a number of community events. They ask their physicians, they ask their nurses, they ask their support staff to go out and be a face of the community in the community for CHI. And then besides just community events or community affairs, internally, we really try to um, determine what the community needs are and focus different projects on that. So, for example, I know Shanika, we talked about like Black maternal morbidity and mortality. So, CHI has a grant, like the Common Spirit Foundation provided a grant for like almost $600,000 to help support that initiative to um, reduce the Black morbidity and mortality rate in our area by supporting Black moms. So not just showing their face in the community, but also putting their dollars behind different initiatives is going to be really important. And that's going to be what helps build trust in our community too.
Totally agree with what they both said. I would say also integrating these type of models, community-based models, like Dr. Bossa was saying, into what goes on in daily operation to be able to show the community that the healthcare system has buy-in to what we're working on, and uh, to meet our clients halfway, meet them where they are, to where, maybe a doctor or the healthcare system can't actually go to someone's house, but guess what? We have a community health worker program or a doula program that can go into the home and be able to support those type of things that they might need and help them recognize the different things that they might need help with, that they do need to go to a doctor to, and be able to provide that information and just help add that more trust with them and give your perspective about going to see a doctor and just being that team and being that village, and also being that, community. We do community baby showers, and we have doctors come, and when the client or a patient sees their doctor out in the community, that fills their heart like, oh my gosh, you're here in the same place where I live. So being able, that breaks down barriers also too. So just knowing that us here in Omaha, Douglas County, or wherever we're working to do this work, that we all are doing this work and that we all are here, and that our clients and community can see that.
That's great. So if part one of my question was how can the healthcare system reach out into the community most effectively, part two is what's the role of community-based organizations in serving to mediate and restore trust between their communities that they exist in and the healthcare system?
Yeah, I would say just bridging that gap, giving that information, letting them know that this is trusted information and that we trust this healthcare system, and that they are here to uh, better involve you and your own care and different things like that, and just showing them that we are, like I said, a village, and that a team, and that we're here just gathering the data to be able to have give to our stakeholders and different things that we do to be able to uh, better our care. We do the IRB and different things like that, to be able just to show that what we're working on and what we're doing can also be implemented in healthcare systems too.
I think the information that the community organizations receive from their clients, because they're so integrated with a lot of the different departments within our healthcare system, they can bring back information to us so then we know what we might need to focus on next. So if Shanika is getting, I never know if I should say patients or clients. If Shanika has clients and they are all kind of worried about a similar issue, she meets with enough of us that she could bring that issue up. And maybe that's something that we need to address in the next year's discussion about the next community needs assessment.
So essentially kind of their ears to the ground, hearing the things that you might not otherwise hear that you need to hear to adapt.
Absolutely.
Selene, thoughts that you have about the role of community organizations that have been offered?
No, I think I would say the same thing. They are the closest ones to our community members, and they are a safe and trusted organization in our community. So they are more likely to hear those concerns from those patients. And then they know the trusted partner in the healthcare organization to bring those concerns to, but it does take a village.
Wonderful. Now, I will invite people. We're going to, I have plenty of things I can continue to ask, but I want to make sure that we give all of you a chance to ask your questions. So for the folks online, feel free to start putting some questions into the chat or signaling in whatever way you choose to that you have a question, and we can let you ask that question. So let's start collecting those. And similarly for the folks in the room, invite you to think about questions you might have as I at least do one more question here as you start to think about yours. So I recognize that cultural concordance isn't the end all and be all. I don't want to suggest that it is, and yet I still believe that it's a pretty important element that we have not necessarily done the best job of on the health system side meeting our obligation to have culturally concordant opportunities for those patients who desire that. That's true at a provider level, but it's true across the board. I think, Selene, some of your examples in the OR highlight just how important that cultural concordance can be across the whole spectrum of care. I'm curious what your thoughts are about the role of universities, the role of the healthcare system, or the role of the community in better optimizing pathways into healthcare careers for youth or second career opportunities for folks to come in at any level of healthcare to help better overcome those discordants between patients and providers in the healthcare team.
I think I'm a personal example of how well that works when community, your educational partners, healthcare systems come together and provide those pathways to students. So I'm a first generational student, Mexican immigrant parents. My father had no education. My mother had a third grade education. I came to Omaha, Nebraska at the age of 14, graduated from Bryan High, so the first one to graduate high school, attended Methodist College, became a surgical assistant, then attended UNO, had a bachelor's in science, and then I started working in surgery. Now my daughter graduated recently from UNO with a master's in science education. And so just with that opportunity that was provided to me from a healthcare career camp that I attended at one of our local CHI hospitals, Midlands Hospital specific, that's where I first saw the role of the surgical tech. And that's really interested me in getting into healthcare. But I couldn't really see the way of how was I going to be able to finance college or any sort of certification. And then I didn't have the role models at home that could really guide me to get into a university. So that was a lot of work that I had to do myself. But it really shows, with people when I went to my counselors and I talked to community people that I trusted, they really believed in my dream and they helped me apply for different scholarships. So there was a scholarship provided by Methodist Hospital, and that paid for my training, and then a scholarship through UNO as well. And so providing all those, recognizing the social barriers that a lot of our students have from diverse backgrounds, and then being able to put those in place within universities and healthcare systems really changes the trajectory of a person, and not just a person, but it changed my life, it changed my children's life. And now I am trying to give back as much as I can to my community because of my experience. So So I feel like I have really served as a role model to be able to open those career pathways. I now lead a regional workforce development program for CHI that provides those scholarships for students, diverse students that are interested in healthcare. So we have a full tuition program. They become CNAs. We onboard into our clinics and hospitals, and then we provide that support internally for them to grow in healthcare. So again, it's like really looking into what are the social barriers, working with those students. Not everybody has the same opportunities, even though they are in the same neighborhood. And then really just that internal support, providing mentors and assistance as you go, because it pays back. It's an investment. It's a long-term investment, but it pays back.
It definitely has to start well before the university level. If you wait until then for some of these career paths, it's a little bit too late. So having programs that will support, I guess if I were to think about physicians or dentists or things like that, you need to start a lot earlier and having programs that will help push through minority students that might be interested. Because if they don't see those role models, then they won't know that that's an opportunity or a possibility for them. But then also the healthcare systems need to have people from every walk of life so that when the young kid goes to the doctor, they can see a doctor that might look like 10 different people in their community. So we need more DEI initiatives versus less DEI initiatives, because all that does is give more people an opportunity to be in a position to serve and help others later on. So elementary school and high school, if you live in certain neighborhoods, you're not going to go to the best schools and know how to take exams and get into the best colleges and get the scholarships that you need. So we've got to really invest from a young age in order to get enough people to be able to have the diverse workforce that we want later on.
Totally agree with both of you. Like Selena was saying, just as a child or when you first begin, you start dreaming, you think about what you want to do. So, like Dr. Boston said, seeing you, someone that looks like you or is in the same neighborhood as you. I grew up around here, and coming here to Creighton, I did a sports camp here. There was different opportunities throughout my childhood where I was able to come to Creighton, and so being able to see other different aspects that you might have not seen in the neighborhood that you grew up in, and being able to have doors open for things that, oh, okay, I can do that, or I might be able to do that. Oh, opens. Oh, sorry. Can you guys hear me now? Sorry. Being able to open up different doors that might not be available to you in the neighborhood maybe that you grew up in, being able to see yourself in the different aspects, but being able to have universities have those different pathways and going to meet children younger and open up those doors for them, and not so similar settings, or like not maybe in a hospital, but might be at a school or at a daycare, different things like that.
So I hear consistent themes of starting young, providing role models, recognizing that it's not a one and done, though that wasn't exactly the words you used. I think, Selene, your examples of you need the role model. You may also need the scholarship support and help in finding that. You need the mentors to help you navigate the system to get to the place you want to get to. The role model may not be enough if they also can't be a mentor. Are there other keys to success in developing the pathways and getting people through those pathways, again, both for clinicians as well as for the rest of the healthcare team? That pretty well covers it. Okay. Well, and I do think embedded in your answers was a realization that the university has a role, but not the role. The community also has a role, and members of the community who can step up as leaders and mentors and role models, and that the healthcare system has a range of opportunities, some of which Selene represents in her day job, to help to ensure that these pathways lead to jobs and professional growth. So I think that's wonderful. I'm going to pause and see if we have some questions. I see a hand up, waiting for you to shut up, which is a good sign. So I will do just that, and we'll actually. Why don't we? That mic seems like it's a better one. Why don't we keep that one here, and I'll bring mine out. This.
Hello, ladies. Thank you for responding to all those questions. My name is Deyanna. I work as a public health educator, specifically educating about organ and tissue donation in communities of color, which is pretty tough. Um, but I'm also a part of my community here in Omaha, my Latino community. I organize the Cinco de Mayo and Fiestas Health Fair within a community-based group. And one of the things that I've been thinking a lot of is just the healthcare in general of physicians that are not of color, right? And the type of training that they're receiving and what the system is doing for doctors that might be older and not as versed in some of the newer efforts in health equity. And so I don't think that also we need to be the ones to teach everybody how to be open to diversity. I think that that pressure should really fall into systems. So I'm wondering what you have seen in the field that has been successful or is promising in being able to further educate our health professionals to be more inclusive and really look at that health disparity and bridging health equity.
I would say that I know some community organizations are outgoing and partnering with hospitals that does, other trainings outside of what they might do, different bias trainings that go in and talk about different ways are, for OBGYN or maternal health that are able to support in uh, them learning how to adjust or be able to care for meet people where they are. That's what I've seen being done in the community so far. And I would also say just the different pilots and different things and studies being done also helps out too.
The different health systems have lots of training modules for us to do on a regular basis. A lot of it addresses diversity and implicit and explicit bias. But I think ultimately it's going to be on the individual to decide that they want to do better or be better and figure out what that means. How are you going to take better care of your patients that are not exactly like you? You have to go and do the work on your own. I mean, you can't make it be someone else's issue.
I know just as a matter of coincidence that Ashley Carroll, who's been very helpful in a lot of ways with our policy series, including this one, just got off a call on health equity with leadership from across CHI. So Ashley, I wonder if you have any thoughts you'd like to add on that or anything else.
Sure. Well, be careful what you wish for when you give me the mic. Yes. Okay. Okay. You hear me? Yeah. I mean, Common Spirit Health. Part of our mission is to advance social justice for all. It's unprecedented, and it's explicit commitment to social justice. I think, and often what you hear from leaders in this nascent healthcare organization is the mission is what drew me to the work, right? I practice medicine or I work in healthcare, and I have lots of different options where I could practice or put my roots in another way. But it's that common grounding and that shared commitment. Within our central region or upper central region, which includes the Omaha Metro, Nebraska, Southwest Iowa, North Dakota, Minnesota, we have stood up market health equity leadership councils. Every hospital has a designated health equity liaison. Every hospital has a health equity action plan that they're working on. And it's not, what we've strived for is not a standalone plan that is independent, right, of all of the other things. We've actually tried to align as many accountabilities to achieve that synergy, right? So that it's not one person or one role's responsibility to carry the water for this work, that it's infused throughout all that we do. And so we've organized our health equity strategies around three pillars or verticals, and that's our patients, right? How are we identifying disparities in care and outcomes? Our people, right? How are we being intentional in ensuring that our staff and our providers reflect the communities and the patients that we serve to provide the best possible care? And then our communities writ large, right? Hospitals are anchors in their community. So we can use lots of different tools, such as our local purchasing, the jobs that we provide in a community, and the investments that we make in addressing the social determinants of health in a community, such as the availability of safe and affordable housing is an example of that. Did I answer your question, or is there anything else?
I think that augments the perspective. I want to go to one online question, and then we'll come back to an in-person question. Sam, the mic to make sure everyone hears it?
Okay, the first question we've got online is states, one concern I have is the recent post-pandemic use of masks by healthcare providers and students. This creates a barrier and may contribute to the sense of distance or reduced personal connection, which can affect trust and reinforce imbalance of power. This is similar to issues experienced with ICE. While masks may serve a protective function, is it worth considering how they may inadvertently shape a patient's experience? And then physicians at Mayo Clinic do not wear white lab coats for this stated reason. So any comment on that is appreciated.
I think the people who choose to wear masks now in the healthcare system are mostly wearing them because they may be ill. And I think patients don't always realize if a clinician has a family member at home going through chemotherapy, they don't want to bring germs home to that patient, to their family member. Or if you came in because your chief complaint was a cough, I don't want your cough and your germs, so I will put on a mask. So I think people should not always think about it's something against them, but think about maybe why is that healthcare clinician choosing to wear that mask. At our office, if you come in with a cough or fever or whatever kind of respiratory symptoms, we ask you to wear a mask because we want to keep you safe, but we also want to keep the other patients that come in and the clinicians safe. So I think not just related to masks, but just in general, if we all take just one step back and think about not just ourselves, but the other person, why might they be making this choice? Is it really about me or is it about them? So I don't wear a white coat because they're germy, but I also deliver babies and don't want wet things on my white coat. But everybody in the hospitals in a lot of these settings wear white coats, whether they're physicians or dietitians or whoever else. So I don't even know that the white coat is as significant or meaningful as it used to be, where you could identify that was your physician wearing a white coat. Should we get back to that in some settings? Sure. Some people put their white coat on if they have to give bad news or if they are at some professional panel or another and they need to let people know who they are. But a lot of that stuff is just very external, and I can build a relationship with you whether I have on a mask or a coat.
I do think that question, and in some respects, as I was reflecting on all of your answers, including Ashley's to the previous question, does call out that there is still a disconnect between what patients understand to be true and what may be happening within the healthcare system or within the healthcare providers. And certainly, I think there is an opportunity for the engaged or activated patient to better understand that there's also an obligation, I think, that the healthcare team has and the healthcare system has to be thoughtful about unintended perceptions that we give. I think the white coat is probably one of the more overt examples of an imposed social distance. I'm the doctor with the long coat. Let's make sure you know that as we engage in this encounter is not the most welcoming, inviting stance to me. Even if it does allow me to hold a few more pens than I might otherwise be able to hold in my pockets. So I think it is, I think the question is an interesting one for me, at least, in sort of making you recognize that it's not just the white coat. There are other things that we may inadvertently be signaling and thinking about how as a system and as we as individuals in the system can anticipate and mitigate the consequences of those visual or other nonverbal signals that we're giving. And my thought on Ashley's comment here, I go, sorry, I'm on a soapbox. You know, all the good things that a health system might be doing, focus on health equity, might be completely invisible to the average patient. And the health, if we're thinking about ways to show that we care about all patients, that shouldn't be the case. So anyway, just some of my reactions to the last comments. Let's go to a question in the room. Rebecca.
Can I make one comment too? I know we're talking about, breaking down barriers. As a young appearing brown woman, there were a lot of times where I did wear a white coat. You know why? Because if I walk into a patient's room, I was automatically assumed to be the housekeeper or the person that's going to change their bedpan or the person who's going to bring their dietary tray. But if I had on my white coat, then maybe that patient or their family member would think for 1 second more that maybe I'm more than what they thought because I don't necessarily have the face of the physician that they thought was going to come in their room. So while patients may think that it serves as a barrier, sometimes it serves as a badge to say, this is really who I am, and sorry, ma'am, I don't know where your dinner is right now.
You just read my mind, which was going to be my question. I feel like one of the things I worry about in healthcare is not just the erosion of trust in the system, but the erosion of trust and expertise. And I'm wondering for the three of you, how you have battled this idea that the expert is, typically if you were a white guy in a lab coat, you may not have to worry about your expertise being questioned or wondered about. But now I do feel like, anybody can be an expert. Have you felt that erosion of expertise or feel like you have an extra step of having to fight for your own expertise as healthcare professionals within your arena? And B, how does the healthcare system take responsibility to address that issue? Sort of the opposite of, how do we deal with the white male physicians, but what about white male patients? We're saying, where's my dinner, right? So I'm just wondering a little bit about your experiences with that and how the healthcare system has addressed it or not addressed it.
I don't know that we've done a great job with the explosion of social media and TikTok. Everybody is an expert and most of them really are not. Like, maybe 18 or 19 years of training we do. I don't know. When you think about college and medical school and residency and fellowships and all of these things, we really do put in a lot of time to look at literature and research. And people say, I did my research, but Dr. Google does not count because you will find whatever you want, positive or negative, to go with whatever views you have on Dr. Google. So really taking the advice of people who are scientists and clinicians is going to be the best opportunity for you to get reliable information. Just because there's someone who has a huge social media following does not make them an expert at all. And it's kind of difficult to combat that for a lot of patients. And in 15 minutes, I can't pull out every article to show you why that person in that 30-second clip was not right and why this is a better position. The healthcare systems have to get on social media and have people who really do have the experience, because that's how people are consuming so much information. So you want to have people who really are trusted physicians or nurses or pharmacists that are able to explain and do things in those same snippets of 15 or 30 seconds, because people have zero attention span at this point, so that you're kind of pushing back on some of the people who are just popular but don't really know what they're talking about.
I would say, as far as what doula care and doula work, it at the beginning of us, as it becoming a thing here in Nebraska, over in other states like maybe East Coast or West Coast, it was more relevant. But since we've been doing more doula care here, having more doulas, go through their training and different things. At the beginning, it was very hard to be able to have physicians take us serious or be able to understand that we were here supporting them in another way. We weren't just a friend or a cousin or a sister, but really had that lived experience and that knowledge from being maybe in the same community as them, maybe growing up, or being in a medical field in another setting. But here we're working in community and being able to be that bridge and that liaison. I think over these past, I believe, 5 years, we've been really doing the doula care here. I feel that it has changed because of all the different organizations and nonprofits and different things like NPIC, Omaha Better Birth, IBBG, just bringing the attention to doula work and the care that we give, and being able to bridge that gap with the healthcare and the communities.
I think we can go back to another online question and then see if we have another one in the room. Oh, sorry, that's Mike.
Do you want the fun question or the harder question? Maybe we'll save the fun one for the end. We've got a question about medical education. It says the LCME has recently removed the encouragement/requirement to teach about structural barriers. How do you think this will affect medical education?
Doctor.
I don't think it's a great idea. I would like to keep my job, so I don't want to say everything, but I mean, our world is so diverse. It is not just what it used to be. There's going to be so many different patients and people that we interact with, and we have to understand that everybody is going to be a little bit different. Everybody cannot be treated the same. You want them to be treated fair and you want equity, but there's going to be differences that need to be addressed. And, you know, for these institutions to think that it's a good idea to not have that kind of training in their system is just kind of ridiculous. But I mean, when you look at what our nation's leadership looks like right now, it's all pretty ridiculous. So I'm not really surprised that some of this stuff is changing, but I think the people who are still in these positions, while there might be all of these new guidelines, I think the people that are on the front line doing the jobs will still try their best to address some of those concerns on a local kind of in-person level, even if the national bodies are saying we don't want to do this or we don't recognize X, Y, and Z.
I would just add from my perspective that yes, the federal policy right now and the federal climate right now is anything but logical as it relates to addressing what should be a unifying goal of health equity. We spoke earlier about workforce and the need for more DEI. What have we seen? We've seen a retreat. It's been very overtly federally pushed in more ways than any of us have to talk about. I think this LCME example is just another one of the examples of the retreat in the current climate, political climate. I guess I'm enough of a glass half full person on this that I share Deyanna's perspective that there is a widespread enough recognition amongst the people who are actually doing the work that health equity does still matter, that having a diverse workforce is an important goal, even if we can no longer admit our medical students or other students based upon those criteria overtly, that the diversity is still a goal that is worthy of pursuing because it leads to better care and greater equity in access and quality of care and outcomes of care. There's been a lot of title changes. My previous employer, the AAMC, no longer has their chief of diversity, equity, and inclusion by name. They have someone who's very committed, because I know her well, to that work. And so I think there is certainly a facade of retreat, but I really am hopeful that there is a core at both the local and national level from our associations, accreditation, and advocacy, as well as our local leadership that will sustain what is really needed in this space. But it's not accelerating, I think, is the unfortunate thing. Holding steady is probably the best we can hope for in the current environment, and hoping for a brighter day when we can actually advance the things in a way that any of us would like to. One more, yeah. Oh, wait, I'm gonna follow my promise of going in person and hand it to Ash.
Thank you, Dr. Shipman. We've talked about programs and partnerships and the importance thereof, and we've started maybe more implicitly talking about the role of policy and politics in reversing or eroding trust at the population level, right? I've worked with each of you on policy or the aftermath, the impact of detrimental policy. I'm thinking about executive order on immigration enforcement and the fear that perpetuates in the community, the real fear that creates in accessing healthcare. I think about extending Medicaid coverage to 1 year postpartum and Medicaid reimbursement of doula coverage. So my question to each of you, and you can take those examples and expand on those or choose different ones, is just reflect on the impact of the systems that we operate within, right? The policies that are implemented or the political actions that are taken that have really real consequences on trust.
That's a great question, Ashley. I would say specifically in regards to immigration policy and seeking of healthcare system or care within my community, you can definitely see the fear in people of canceling appointments or not showing up to their appointments. But I also think that there is a deeper effect on the person themselves, especially on children. I think we're not going to see those effects until later on. But I can definitely, just being in that community and having maybe family members that have been affected through policy is there is going to be a lot that the healthcare system is going to face in regards to mental health and how it has affected children in those communities that have been affected by by immigration policies. And then also there has been from our community partners communication in regards to patients not seeking treatment for cancer specifically. So there's a lot of patients that are not going to their radiation appointments or things like that because of fear. So I know that with our system, we have really stand in a very positive way of communicating that our spaces are safe for them to come and continue to seek those healthcare services that they need. But then again, also I would want, for physicians and clinicians to really focus on the mental health of those patients that they're serving in those immigrant populations, because we are going to see an increase of needs of mental health care because of those policies.
So specific to the doula care and the doula reimbursement and postpartum being extended past a year, I think of all the different pilots and different things that everybody has been a part of, that community, hospital, legal, different things, being able to go and testify and share our experiences with doula care, or being able to support a patient or client up to a year, being able to women being able to go to the doctor after 6-week postpartum, and just all the different things that go into that, and the care that they get, and the things that they don't have to worry about after they have baby, just because they have that Medicaid care, or because they have that doula being able to support them. But then also it creates a workforce to be able to have in our community that is also sustainable, and being able to bring different things to our community. So being able to go and testify and share our experiences really changed, I believe, that law, and being able to continue and add more to it. So
I think our health system is trying to do a good job. Health equity is important. Building trust is important. Making sure that we're a safe space is important. But we also have to be very realistic that patients have to get to us before they can feel safe when they come into our doors. So I think we're doing a really good job in a lot of areas. But I also think when it comes to politics, people are always towing that line of, if I speak out against something, am I going to be financially impacted or blacklisted or whatever? So, really having a system that is going to stand on whatever their true principles are is going to be really important. And I think we do a pretty decent job of that, even if, you can't say that you have a DEI officer, but you have somebody who's working in the background to keep supporting those kind of initiatives. I think we're trying to do our best.
Should go to an online question that you had teed up. Bring the mic to you.
Okay, the question is for each of you, if next year you received $500,000 grant from Common Spirit, what would each of you spend it on? And let's try to relate it back to any of the number of topics talked about tonight.
How long do I have to spend this money? Because I could spend it tomorrow. I think for me, I really would focus on education. Like I mentioned earlier, education really saved my life, and it really turned my family life because I was provided those educational supports, whether it came through funding for scholarship to be able to complete my certification and then my bachelor's degree. So I would continue to do the work that I do and elevate it in a higher platform where we can reach more people within our region. And also, what I feel, and it's not just the education and the training part of it, but being able to provide those other support systems for people that are going into those entry level jobs, such as partnering with community partners that have the expertise to provide assistance, whether it's transportation, daycare, food insecurity. We can do our part internally to train them as CNAs or nurses or surgical techs. But there's also a lot of other social barriers that people face in our communities. So I would really want to see colleges, universities, and healthcare systems really build that support internally and externally to really grow a person and provide that support as a whole. So yeah, I'll take the money. Thank you.
Maybe I would start a nonprofit that could give tons of like micro grants to people. I think our communities, sometimes people just need a little bit more support. So if you're, I have patients that'll come and say, our landlord is a slumlord and he automatically said that we owe $2,000. What are we going to do? Or I couldn't get to my appointment because our car broke down and it cost $1,500 to repair it. Or I couldn't come because I really needed to go to work. So I think if we had some kind of way to be able to, $2,000, $5,000, $8,000 to get you, make sure you have stable housing for a couple months, make sure your car works so that you can go to work. All of that will allow you to elevate your family, get out of poverty. Maybe you'll be able to go take some different classes as well as work so that you can get to a point where you're able to be a lot more self-sufficient and sustain your families.
Totally agree with both of you. Also, I would say have a workforce development for community health workers that would be able to support all the things, those pathways that they might need help with: housing, food, transportation, legal. But then also maybe having a fund, like Dr. Boston said, for that fund to be able to, if you're having this issue, we can help you with this. We can help you with your housing. We can help you with just that bridge, kind of getting to that next thing. And also, all making sure that all moms and babies are everything's having strollers, car seats, diapers, different things like that. That is a really big thing in need in our community. So being able to provide those little things that everybody might think that, oh, you're having a baby, you're going to get that. They really don't. So until the baby comes out and like, I don't have a car seat. So being able to provide those type of things for families here.
I'm not sure that the question was directed at me. I think it came from Bob Fitzgerald if I saw it pop up. So I'm going to take the liberty of guessing that he's allowing me to answer this as well. I think that there's two things that would be very practical to do with me. First would be if we could pull it off for $500,000, owning the three, to have more people as committed and dedicated as you obviously are to the populations you serve and to embody what it means to be trusted in the healthcare system. Short of that, I would use that to buy out your time so that you could mentor others so that we could generate an additional generation of people who get it. Sincerely, though, you guys really do embody, I think, what it looks like for the healthcare system to demonstrate trust, to reach out to the patients that need it most and to meet their needs. I think that's, at the end of the day, one of the most important things that we can do, despite all of the counter pressures out there today, eroding trust. It's with dedication that we're going to build that trust, and just keeping at it, persistence is key in all these things. So please join me in thanking our panelists today.